That takes us to page K9. On K9, the trachea, or windpipe, I wrote as a 4.5-inch long tube. Again, I never test you on how long a tube is. It goes from the cricoid cartilage of the larynx to the right and left primary bronchi that enter the lungs. You'll notice that I indicated your larynx is at the level of C6, and the primary bronchi are T5. Don't worry, I'm not testing you on that, but I have said many, many times that we kind of use that spinal column as a yardstick so that we kind of know where the different structures are. What is important is the trachea is anterior to your esophagus. It's in front. When you feel the front of your neck, that's the trachea. The esophagus is behind it. It's posterior. The trachea is anterior. Way back on page A2, when we were first learning those terms, anterior and posterior, we gave the example of the trachea and esophagus to know which one is anterior and which one's posterior. Now the trachea and the airways in general are held open by hyaline cartilage. The rings of hyaline cartilage prevent it from collapsing. The inside lining of these airways, including the trachea, is a ciliated mucous membrane. We've learned previously that's a shorthand way of saying pseudostratified ciliated columnar epithelium with goblet cells. We first learned that way back on D5. So that's the ciliated mucous membrane is what we find lining the inside of our nasal cavities and the nasopharynx, and beginning with the trachea all the way down to the air sacs. So wherever there's just air, and only air, that's flowing, that's usually lined by a ciliated mucous membrane. I am not going to test you on the words tracheotomy and tracheostomy, but let me just briefly mention the difference. Tomy means to cut. You know, this is a course in anatomy, where you cut up things. So when you make a cut in the trachea, that's called a tracheotomy. This is what's being done right there as a tracheotomy. Once you create an opening is called a stomy. Stomy means an opening, so this opening is called a tracheostomy. Where we saw that word stomy, or for opening, was a colostomy. Remember, the artificial anus that is made in the lower abdomen was called a colostomy. So I only point this out, I'm not testing you on it, but tomy and stomy are different Greek roots. To means to cut, sto means an opening. So again, just subtleties of the medical jargon. The lungs. Okay, our lungs literally begin slightly above the clavicles. Here's the clavicles, so they actually even begin slightly above the clavicles, and they rest on the diaphragm muscle at the base. The top of the lungs are called the apex, the bottom are called the base. We'll see that in a picture in a moment. And the hilum of the lung. Now we've heard that word hilum. Well, the hilum, we've heard that. The hilum of the kidney. The hilum of the kidney was where all the blood vessels and tubes entered or left the kidney. And the hilum of the lung is where all the blood vessels and tubes enter or leave the lung. And there are a whole bunch of blood vessels and tubes entering the lung or leaving the lung at the same place, at the hilum. This is where the primary bronchus, the airway, enters the lung. There's also bronchial arteries. These are arteries that supply oxygenated blood to all the airways. They need their own oxygenated blood. Our heart needs its own oxygenated blood. Our blood vessels need their own oxygenated blood. The pulmonary arteries are bringing blood low in oxygen to the lungs, and then the pulmonary veins are carrying oxygenated blood away from the lungs to the left heart, to the left pump, left atrium. There are lymphatic vessels carrying fluid out of the lungs, and there are various nerves. To kind of visualize this better, let's look on the next page, K10. And K10 is a really nice picture of the respiratory system. So starting at the very top, here the air, if you're a nose breather, the air flows through your nose. If you're a mouth breather, through the mouth. We know that in the nasal cavities there are those shelves called conchi. the bony projections covered by a mucous membrane. We know that the palate or roof of the mouth separates the nasal cavity from the oral cavity. The front part is called the hard palate. The back part is called the soft palate. The very end is called the uvula. The air would flow from the nasal cavities, actually go through the anterior nares, nasal cavity, posterior nares, or a choanae, and then it would travel down our throat. And we know the upper part of the throat is called the nasopharynx, and the middle part is called the oropharynx, and the lower part is called the laryngopharynx. Branching off here are the two passageways. Food will, of course, be pushed by peristaltic contractions through this muscular esophagus to the stomach. And air is going to flow from the laryngopharynx through this laryngeal aperture through the larynx. And it will pass through that glottis slit between the vocal cords and then down the trachea. Here's the trachea. And here's where the trachea bifurcates. It bifurcates into a right and left primary bronchus. And the primary bronchus is the air tube that enters the lung at the hilum. The hilum of the lung is right where all these tubes and blood vessels enter or leave. And you can see the primary bronchus subdivides into smaller and smaller and smaller branches. Here points out the top of the lungs are kind of pointy, so they're called the apex of the lungs. Look how many times we've seen that word apex. And the bottom of the lung is called the base of the lung. It's flat. This right between the lungs, of course, is the heart enclosed within a pericardial sac. A pericardial sac. This area between the lungs is known as the mediastinum. And you're thinking, whoa, 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 how do you spell mediastinum? That word is written on the top of the next page, K11. Right on the very top of K11 is mediastinum. That's what is the mediastinum? That's the area between the lungs. And what's found in the mediastinum is not only the heart, but the trachea and the esophagus and various blood vessels are in that mediastinum area. Here we see the heart and lungs resting on the diaphragm muscle. And there are holes in the diaphragm muscle. And you might say, well, what do you mean there's holes? So we wrote on the lower left, there are 3 large openings in the diaphragm muscle. There's an opening for the esophagus, for the aorta, and for the inferior vena cava, the IVC. You might say, well, what do you mean? So look, here in our picture, this is the muscular esophagus, and the esophagus, incidentally, is running right behind the heart. Remember how if you have acid reflux, they call that heartburn, because it's the esophagus is right behind the heart. And it has to go through a hole in the diaphragm muscle to connect to the stomach. Here's the stomach right here. We know right where it connects is where the gastroesophageal sphincter is. And there's also a hole for the abdominal aorta, right? The aorta goes through the chest and then passes through the aortic hiatus and then into the abdomen, then it's called the abdominal aorta. And the largest vein in the body, the inferior vena cava, passes through a hole in the diaphragm to bring blood up to the right atrium. Now, the importance of these holes or openings is we have learned that it's possible for an abdominal organ to push through these openings, and if that were to happen, that's called a diaphragmatic hernia. We've talked about inguinal hernias, umbilical hernias, and if an abdominal organ sticks up through one of those openings in the diaphragm and now is protruding up into the chest cavity, that's called a diaphragmatic hernia. On page K11, so let me describe this picture of the lungs. So here's the trachea. It's bifurcating into a right and left pulmonary bronchus. And the right lung, and I wrote right and left here, the right lung is bigger than the left lung. The right lung is made up of 3 lobes. The top is called the superior lobe, the middle is called the middle lobe, and the bottom is called the inferior lobes. There's 3 lobes to the right lung. The fissures that separate these lobes This one is called the horizontal fissure because it's running horizontally between the superior and middle lobe. And this fissure is called the oblique fissure. Oblique means at an angle, diagonally, between the middle and the inferior lobe. And incidentally, the right primary bronchus would divide into 3 lobar bronchi. We're going to learn that term in a moment. There'd be 3 lobar bronchi, one for each lobe, for the superior, middle, and inferior lobe. We'll see that in a minute. The left lung has only 2 lobes. It has just a superior lobe, and way down here, an inferior lobe. And since the fissure that separates the big superior lobe from the inferior kind of runs diagonally at an angle, it's also known as an oblique fissure. Now, why does the left lung have only 2 lobes? We have mentioned previously that your heart isn't really exactly in the middle of your chest. It's left of center, and it's shoved into the left lung, and therefore the left lung is narrower and missing a lobe. We've seen this happen before. We know that our right kidney sits lower than our left kidney because our big liver is on the right side of our abdomen, and it causes our right kidney to sit lower than our left kidney. So the position of these organs affects their shape and their location. Now, these airways divide into smaller and smaller branches until they finally terminate in these tiny air sacs called alveoli. Alveoli, little air sacs. And it's only at the alveoli where oxygen and carbon dioxide move between the lungs and the bloodstream. There is no exchange of gases occurring in any of the other higher airways. Everything I've just described in these pictures was written right here in the outline. On page K12, we have what's called the respiratory tree. By that we mean these airways that divide into smaller and smaller branches. So the primary bronchus is what enters each lung, and it subdivides into lobar bronchi. And how many lobar bronchi there are depends on how many lobes there are in that lung. There will be 3 right lobar bronchi and 2 left lobar bronchi, because the right lung has 3 lobes and the left lung has 2 lobes. It's not complicated. The lobar bronchi subdivide into segmental bronchi. The segmental subdivide into bronchioles. And the word bronchioles or bronchioles reminds us of that word for little arteries, arterioles. Right? So the little arteries are called arterioles, little bronchi are called bronchioles. And the bronchioles subdivide into alveolar ducts, and that finally terminate in these air sacs or alveoli. We can actually see at the bottom of this page, K12, so here is the alveolar ducts and these little air sacs or alveoli. Each lung has about 300 million of these alveoli, as we've indicated right here. We're not asking you to memorize that number, but there are about 300 million little air sacs in each lung. And these alveoli are surrounded by a profuse network of so-called pulmonary capillaries. And it's, of course, there where there's the exchange between the oxygen and carbon dioxide between the lungs and the bloodstream. Now, just in the middle of this page, K12, we are on page K12. In the middle of page K12, I've described some changes in the histology of the wall of these airways as we get to smaller and smaller divisions. And here's what we observe. With each subdivision, as we go from larger to smaller and smaller airways, there are the following 3 changes that we observe in the histology of the wall of these airways. There's progressively less and less cartilage in the walls. Okay, in other words, the trachea has a lot of cartilage in the wall. And we've already learned that the purpose of the cartilage, the hyaline cartilage in the wall of the trachea, is to prevent it from collapsing. So there's no way your trachea is going to collapse. But as we go to smaller and smaller airways, there's progressively less and less hyaline cartilage in the walls, and therefore the smaller airways are capable of collapsing. The little bronchioles really do not have any cartilage to prevent them from collapsing, so they may collapse. Another thing we observe is that as we go from larger to smaller and smaller airways, there's progressively more and more elastic connective tissue. What that means is that your trachea does not have very much elastic connective tissue, so it's not very flexible. It's quite rigid or stiff. But as we go to smaller and smaller and smaller airways, they have progressively more and more elastic connective tissue in their walls, and they become more flexible, And the third change we observe is that as we go from larger to smaller and smaller airways, there's progressively more and more visceral smooth muscle in the walls. And this visceral smooth muscle is innervated by autonomic motor neurons that can cause the visceral smooth muscle to contract, which would constrict or narrow the airway, or relax, which would cause the airway to widen or dilate. Your trachea does not have very much visceral smooth muscle. It cannot really constrict or dilate. The diameter of your trachea stays constant. But as we go to smaller and smaller and smaller airways, they progressively have more and more visceral smooth muscle that is capable of contracting. And that's why we wrote that the bronchioles, the tiny airways, are innervated by autonomic motor neurons that can cause the visceral smooth muscle to contract, which constricts these airways, that's called bronchoconstriction, or causes the visceral smooth muscle to relax, and as it relaxes, the airways widen or dilate, and that's called bronchodilation. On the next page, on K13, so what we wrote next is that our alveoli only begin to develop, of course, during the 6th month of fetal development. That's why we've learned that if a baby is born premature, the most common complications that we observe with premature birth are breathing problems, because these little alveoli or air sacs don't even begin to form until the 6th month of development. The alveoli are very delicate. It's a very thin wall made up of simple squamous epithelium. We've already said that these air sacs are surrounded by a network of pulmonary capillaries. And what we've written next is the microanatomy of the respiratory membrane. We can see this at the top of the page. This is page, of course, K13 at the top. And what we're looking at here is a cross-section through an air sac, or alveolus. And this is also a cross-sections through the pulmonary capillaries that are carrying blood. So here we can actually see in this cross-section through the pulmonary capillary, we can see the red blood cells. And we've described how oxygen diffuses across the wall of the air sac or alveolus, and then across the wall of the capillary into the bloodstream, where most of that oxygen will bind to the hemoglobin inside the red blood cells. At the same time that oxygen diffuses from the alveolus into the bloodstream, the waste product carbon dioxide is diffusing out of the bloodstream into the alveolus, basically going in the reverse direction. We can enlarge this even more by looking at this picture on the upper right. On the upper right, we see here just how thin the wall of the air sac is, the alveolus, made up of simple squamous epithelium. We see how thin the wall of the capillary is, also made up of simple squamous epithelium. And so the route that the oxygen diffuses in and the carbon dioxide diffuses out, it just involves moving across two very thin-walled membranes. At the bottom of the page, we mentioned that there are some special cells in the lungs that we want to draw your attention to. There are what are called type 2 alveolar cells. They used to be known, or are also known as septal cells. We'll call them type 2 alveolar cells. These are noteworthy in that these cells associated with the wall of the air sac secrete a chemical called pulmonary surfactant. And the purpose of pulmonary surfactant is to prevent these very delicate air sacs from collapsing. It's really a phospholipoprotein kind of having a detergent action that reduces surface tension and reduces the tendency of these little microscopic air sacs to collapse. There's also many macrophages in the lungs. We know that the respiratory system is a major entry point for bad guys to get into our body because there are all kinds of viruses and bacteria floating around in the air that we take into our lungs. So we've got a bunch of macrophages in the lungs moving around, ready to swallow up and engulf dust, foreign matter, as well as bad guys, and keep our lungs clean. That takes us to page K14, and on K14 we deal with the so-called pleural membranes. And so what are the pleural membranes? We know that just as there are a parietal peritoneal membrane on the inner wall of the abdomen and a visceral peritoneal membrane covering the outer surface of our intestines, similarly, there is a parietal pleural membrane attached on the inner wall of our chest and a visceral pleural membrane adhering to the very surface of the lungs. Here we can see the parietal pleural membrane identified and the visceral pleural membrane covering the surface of the lungs. These pleural membranes are commonly called serous membranes. And as we wrote in the middle of page K14, they are made up of simple squamous epithelium that secretes a slippery serous fluid, and they secrete this fluid, these two membranes, into the space between the membranes. In other words, these two pleural membranes secrete this slippery fluid into the so-called pleural cavity, which is the space between the pleural membranes. So it is filled with a thin layer of this pleural fluid. And we wrote, incidentally, right here. So the pleural cavity is a fluid-filled space between the pleural membranes. Now, it's very important that in order for your lungs to stay inflated with air, there only be this layer of pleural fluid between the outer parietal pleural membrane and the visceral pleural membrane covering the surface of the lungs. In fact, as we can see in this picture right here, if air were to enter the pleural cavity, the space between the pleural membranes, and in this case it shows that the air was able to enter into this pleural cavity by stabbing with a knife, just the wall of the chest, the knife did not penetrate the lung in this case, but that was enough to allow air to enter into that pleural cavity. And when air does enter that pleural cavity, that's called a pneumothorax. The word literally means air in the chest. And as air starts to flow into the chest, the lung pulls away from the chest wall, and it results in either a partial or a complete collapse of the lung. Now, the way that they would try to deal with this pneumothorax, resulting in a partial or complete collapse of the lung, is they would actually insert a syringe with a needle, a hypodermic syringe with a needle, into the pleural cavity, and they would aspirate up. They would draw up on the syringe, drawing the air into the syringe, and as the air is drawn back into the syringe out of the pleural cavity, that in effect acts to reinflate the lung and allow it to reattach to the chest wall. So that's the importance of these slippery serous membranes or pleural membranes. Now, I'm not going to describe the embryology of the lungs. I know everybody's going, darn. So we're going to skip pages K15 and K16, which takes us to K17. On K17, so we're going to speak briefly about pulmonary ventilation. What is pulmonary ventilation? Pulmonary means lungs, and ventilation means breathing. Breathing. How do we breathe? You know, it's in goes the good air, out goes the bad air. But how does that work? We're going to remind you that in order for us to inhale, these breathing muscles have to contract. And the important breathing muscles are the diaphragm muscle, and you've all seen the diaphragm on the cat, right? That separates the chest from the abdominal cavity. and the intercostal muscles, the muscles between the ribs. Intercostal literally means between the ribs. When these muscles contract, that actually increases the chest volume. So when you contract these respiratory muscles, that enlarges the chest volume. And that actually creates a suction that sucks or draws the air into the lungs. Let's see how that works. In the picture at the upper right, so here it shows, here's the trachea, the primary bronchi, the lungs. The lungs are resting on the diaphragm muscle. When the diaphragm muscle is relaxed, it actually arcs upwards. That's the position of the diaphragm muscle at rest when it's relaxed. So, and the diaphragm muscle is attached here and here to the wall. Now, when the diaphragm muscle contracts, somebody remind me, what does the word contract mean? What does contraction mean? It means to shorten. To contract is to get shorter. So the diaphragm muscle is going to get shorter. Does anybody remember hearing the following expression? The shortest distance between 2 points is a straight line. Remember that? So if the diaphragm muscle is attached here and here, as it gets shorter, it actually becomes a straight line. Can everybody see that if this is how the diaphragm looks when it's relaxed, and this is how it looks when it contracts and gets shorter, becomes a straight line, can you see how that's made the chest bigger from top to bottom? So when the diaphragm muscle contracts, the chest becomes bigger from top to bottom. When the intercostal muscles contract, that enlarges the chest, the rib cage, the chest, from side to side and from front to back. So the contraction of these breathing muscles enlarges the chest volume. And that actually lowers the pressure in the chest and in the lungs. Now, for those of you who have had chemistry, this is called Boyle's Law. In chemistry, there's a concept called Boyle's Law where pressure is inversely proportional to volume. Now, I'm not testing you on Boyle's Law for this anatomy class. I'm only mentioning it because some of you have had chemistry or you will yet take chemistry. But this basically says that when you expand a volume, the pressure inside that volume goes down. So if you're enlarging the chest volume, it lowers the pressure inside the chest and lungs, and that creates a suction. And that's exactly what we wrote here, is that air is actually sucked into the lungs as the chest gets bigger. You know, an example of what I'm describing is an accordion. So when you have that accordion, when you expand the bellows, it draws air into the bellows. Now, when you push in on the accordion and you make the volume smaller, it blows the air out. So, and that's what we wrote here, that when the diaphragm and intercostal muscles relax, the chest volume gets smaller. You'd say, what do you mean? Look, here I'm looking great. Let me relax my breathing muscles. When you relax them, your whole chest volume gets smaller. And if the volume gets smaller, the pressure increases. So air is forced out. It is blown out of your mouth because the pressure rises. So that's what it shows here. When the diaphragm muscle, so here it shows the diaphragm muscle contracting. Here it shows the diaphragm muscle relaxed. And that affects the size or volume of the chest, and the pressure goes in the opposite direction of the volume. Increasing the volume lowers the pressure, creating a suction. Relaxing the muscles reduces the chest volume, raising the pressure and forcing air out. Or another way of saying the same thing is inhaling sucks and exhaling blows. So just remember, inhaling sucks. When we inhale, and you can go ahead and inhale right now. Can you feel the suction? Can you feel the air flowing through your mouth or through your nose? You're sucking it in. So inhaling sucks and exhaling blows, and as I always like to remind you, you should suck when you're supposed to suck and blow when you're supposed to blow. Don't be sucking when you should be blowing, and don't be blowing when you should be sucking. Okay, so blowing and sucking. All right, this is page K18, and as I try to do with most systems of the body, is to describe briefly some examples of disorders and pathologies, diseases associated with that system. So the first one, respiratory distress syndrome of the newborn. This is, we know that the air sacs or alveoli only begin to develop beginning at the 6th month of fetal development. So babies are born. Type 2 alveolar. So it's associated with the deficiency of this chemical called pulmonary surfactant that is produced by the type 2 alveolar cells or septal cells. What is pleurisy? Pleurisy or pleuritis is in fact, that can even lead to the next term, pneumothorax. Pneumothorax literally means air in the chest, and there are a number of ways that air can appear between the parietal and visceral pleural membranes in the pleural cavity, but anytime air does start to appear between those pleural membranes, it results in a partial or complete collapse of the lungs. What is a cold? In these mucous membranes of the throat, as well as enlarged tonsils and lymph nodes, because these lymphatic organs this is a viral infection. You to run a fever. And a pneumonia is the generic term that's used for a general inflammation or infection of the lungs. Again, a lower respiratory tract. And depending upon what's causing the pneumonia, it can be very severe, and especially in those who are immunocompromised, who have a suppressed immune system, either by virtue of being elderly or being on medications or treatments that have suppressed their immune response, it can be fatal pneumonia. Tuberculosis, called Mycobacterium tuberculare. The airways are very sensitive, they constrict, That's called bronchoconstriction or bronchospasm. There is a release of a lot of mucus and fluid, creating urination. Emphysema is associated with a chronic progressive degeneration of the lungs associated with fibrosis of the lungs and atelectasis. All right, what does all that mean? Well, let's look at a visual. This is what normal lung tissue looks like. These are the air sacs or alveoli. This is what the lungs of somebody with emphysema look like. And the first thing we're thinking is, where's all the air sacs? What's happened to all the alveoli? The answer is these alveoli, these air sacs, degenerate. They deteriorate and they collapse. So we get a chronic means it doesn't go away, it doesn't get better over time. Progressive degeneration, that means it gets worse with time, it doesn't go away and it gets worse. Associated with fibrosis, fibrosis means scar tissue formation in the lungs, and atelectasis. Atelectasis means collapsing of the alveoli. So the alveoli collapse, that's called atelectasis. Will develop emphysema. And you probably have seen people with emphysema. These are the people who are too weak to walk, and they drive around in these little electric carts at the market or Costco. They are usually carrying their air tank with them because they don't even have enough lung capacity because of the destruction of all their air sacs. So they need to take in additional air in the form of using a pressurized air tank. At the bottom of the page, carcinoma of the lungs. Carcinoma of the lungs is lung cancer. We've previously mentioned that lung cancer is the #1 cause of cancer death. It is not the most common cancer. The most common cancer is skin cancer, but that does not usually result in death. Because when somebody notices something doesn't look right on the skin, they go to a dermatologist and they remove it. But in the case of lung cancer, by the time somebody one last term under clinical terms, apnea. Now, if pnea means to breathe, as in the word dyspnea meant difficult breathing, apnea, when we have the prefix a or an in front of a word, that means without. So apnea means without breathing.